एक बार चालू कर दो जल्दी से। एक मिनट बंद करना, 1-2 मिनट रुक के चालू करना।
संदीप जी,
अरे चाका तो
या डॉक्टर इंद्रनी।
हेलो
या सर, टेल मी।
is my network okay?
योर नेटवर्क, या आपका रिसीविंग इज नॉट गुड, अपलोडिंग इज क्वाइट गुड।
Receiving I can see receiving is little bit bad.
या हेजी एंड ब्लर आ रहा होगा।
हम्म।
तो आपका दूसरा वाला कहाँ है? दोनों में ही खराब जा रहा है क्या?
नहीं
ओके।
दोनों में नहीं, मैंने बेटर वन स्विच ऑन किया, बेटर ऑन जो वाईफाई है उसमें मैंने कनेक्ट किया है, इसमें हो रहा है। पहले तो
हाँ
अच्छा
हाँ
था, प्रीवियस वन वाज गुड, तो आई कैन स्विच टू द प्रीवियस वन। दो
हाँ
है
हाँ,
मेरे
अभी तो
पास।
टाइम है, यू कैन डू। क्या बोल रहे हो शार्दुल?
नहीं, आई थिंक दिस वन इज बेटर बिकॉज इसमें 360p आ रहा था। वो 90 जो है वो इसकी वजह से आ रहा था कि आपका सिग्नल 90 पे भेज रहे हो, 160/90, मे बी बिकॉज ऑफ दैट।
अच्छा, मेरा भी जा रहा है ना आज।
हाँ, तो उसकी वजह से उनको 90 मिल रहा था, अदरवाइज वो नेटवर्क सही था, मतलब 360p सेंड कर रहा था।
मेरा अभी मेरा ठीक आ रहा है।
आपका मुझे नाइन सेंडिंग आपका 160/90 है, तो उसकी वजह से आपका वीडियो थोड़ा सा मुझे ब्लरी आ रहा है, तो
हाँ
उनको भी ब्लरी
मुझे भी
आ रहा है।
ब्लडी आ रहा है संदीप जी का।
आप थोड़ा
मेरे को भी
संदीप
वही लग रहा है।
डॉक्टर
मुझे भी
इंद्र जी
संदीप
का।
जी का वीडियो। हाँ
हाँ, आपका वो सही है सर, नेटवर्क मुझे वो कुछ प्रॉब्लम नहीं लग रहा है। विल
हाँ
चेक विद डॉक्टर वंस, एक बार डॉक्टर आ जाए
ठीक
तो
है।
पता चल।
ठीक ठीक है, मेरा इशू नहीं है, मेरा दो एक्चुअली क्वाइट स्ट्रांग नेटवर्क है, दोनों में एक चलेगा तो काम हो जाएगा, दोनों ही चल रहे हैं अभी, बोथ आर रनिंग।
ठीक है।
डॉक्टर इंद्र ने संदीप जी स्पीकिंग टू डॉक्टर अश्विनी मेहता, तो कुछ
हाँ
टेक्निकल
ठीक
है
है।
तो हाँ
ठीक है।
ठीक है।
हम्म।
हाँ, प्रेजेंटेशन।
की बात हुई।
हाँ हाँ मैडम, बात हुई। He has no problem. The only thing about the presentation he was telling, I said
ओके।
you can download the app for the Mac and then he can join. ब्राउजर से कई
ओके।
बार दिक्कत आ जाती है प्रेजेंटेशन में।
अब वो कुछ तो वैसे ही कुछ अपलोड और ये कह रहे थे, मैंने कहा एक मिनट में बात कराती हूँ आपसे।
नहीं, वो प्रेजेंटेशन अपलोड का बात कर रहे थे। आई टोल्ड देयर इज नो नीड फॉर प्रेजेंटेशन अपलोड. He
ओके
has taken the ID,
ओके।
but I'll just tell him that we have got the presentation.
प्रेजेंटेशन तो आई हैव सेंड यू ऑन द सेकंड मेल।
ಏನು ನೋಡ್ಕೊಂಡು ಪೋಡು ಚಾಮಡಿಯ ಯೂಸ್
Yeah, good evening.
Evening, sir.
Yeah.
So we have Dr. Indrani, our moderator, and we
Yeah.
also have Mr. Sandeep from the technical team. He has called you. So,
Okay.
sir, first we'll finish the technical part, and then Dr. Indrani can discuss with you and Dr.
Sure.
Bharadwaj.
Sure.
Sandeep,
Sure.
One minute.
Take your time. शान मुझे पानी दे दे.
Are you able to download the app, sir?
When I joined, no, it was difficult to download the app, so I've joined directly from the
Hello?
browser. Yeah, I joined directly from
Are
the
you able to
browser.
download the app?
I'll download it again. Let me try it. I was not able to do it. Yeah, I'm able to download it now again. I'll join it from there if you want me to.
it's better to share the
That will
screen.
be better. Yes.
Okay.
Good evening, Dr. Ashwini. This is Sandeep here.
Yeah, Sandeep. Yes, Sandeep.
How are you, sir?
Yeah.
Yeah, how are you? Sir, I think you have joined via browser.
Yeah, and I've also downloaded that app. I've downloaded it again. It's going to open up.
Okay, great. So once it opens up, and meanwhile, sir, I have your presentation.
Yeah.
Yes, so two things, your signal is coming okay, and also your voice is coming good. So I'm just waiting in case if the app is, you are able to download the app, maybe we can guide you through screen share also
Opened it.
with the same.
That's it. I've opened it.
So you need to log out from this browser.
I'll log out
Yeah.
from this browser
Yes.
and then we go out. Okay.
Correct.
So
Yeah.
I think here I log out.
Join as guest, na?
And you have to join as a guest, sir.
Is disconnected.
Dr.
Disconnected?
Bharadwaj?
अभी दिख रहा है मेरे को तो.
Then he has logged in again from the app. Yeah.
No.
Dr.
It's
Bharadwaj?
browser.
अभी browser ही है मैडम. We can drop that actually.
One second, I'll call Dr. Bharadwaj. I'll just ask him to switch it.
संदीप सर वो इंट्रोडक्शन वाला प्रेजेंटेशन आप शेयर करोगे?
नहीं, डॉक्टर इंद्रनील विल शेयर ना.
ठीक है, क्योंकि आपका नेटवर्क है ना थोड़ा सा आज जरा स्टेबल है.
किसका? मेरा ना.
हाँ.
हाँ सर. हेलो.
Is it okay?
Yes, just checking. Yes, it is on my app now.
Yes, sir.
Yeah, fine. So you have my
Yeah, I can
slides.
see you now.
This. Okay, so I can share my screen also, is it?
Yes, sir.
Yes, sir. On the yeah. Sir, on the top next to mic, there is a share screen button.
Yeah,
I'm just giving your presentation.
Sir has done that. Yeah.
Sir, just minimize it from the top left, yellow button.
Yes, sir.
Just a moment,
We just
just a
have to
moment.
call Dr. Bhardwaj to.
सर टॉप में जो राइट इसको भी मिनिमाइज कर दीजिए सर आई थिंक
Okay. Are you able to see my screen?
Yes.
यस द सैंड ड्यून
Yeah, sand dune.
जस्ट ओपन द
Yeah.
पीपीटी सर
Okay, I will. Just a moment. You're able to see that?
Yes, sir.
सर
That's
अभी
fine.
ओपन हो रहा है
हाँ हो गया.
Beta blockers, yes.
Isn't
Beta
it?
blockers
Are you
in
able to see?
hypertension and heart
Yeah,
failure. SBP,
या
DPP, beta
एसबीपी
blocker.
डीपी यस इट इज रनिंग प्रॉपरली
Right.
Okay.
सर थोड़ा सा स्क्रीन आप ऊपर कर लीजिए आपका फोरहेड थोड़ा सा कट रहा है सर हेयर्स
Got it. We'll do it. अभी करता हूँ.
या
Is it better now?
दिस इज
Is this better?
ठीक है. No issues. No issues.
या सर इट इज बेटर
Yeah, I think Dr.
थोड़ा सा
Indran
लैपटॉप अगर
थोड़ा ऊपर,
लैपटॉप का
सर,
ये नीचे
थोड़ा-
किया तो हाँ हाँ
This would be okay.
लैपटॉप का स्क्रीन
हल्का सा नीचे कर दीजिए सर
हल्का सा या वी कैन
हाँ अब बराबर है अब बराबर है
अभी वापस
ठीक है.
कट गया आई थिंक
अब ठीक आ रहा है
Yes.
दिस इज फाइन सर
यस अभी परफेक्ट है सर
ठीक है.
ठीक है कैन वी कॉल डॉक्टर भरद्वाज मैडम
We have
सर
already called
राइट
him.
नाउ यू कैन डू स्टॉप शेयरिंग
I will do that. Just a moment. So here is the stop sharing.
Dr. Mehta, I'm
and
Dr.
at
Indranil.
any point sir
Yeah. Yeah. Hello.
So I'll be the so I'll be the moderator for today's program.
Perfect.
But
Hello.
Good evening,
Dr. Bharadwaj has joined.
Hello, Dr. Ashni, how are you?
Fine. All good.
Great. Nice to see you after so long.
Yes.
And now we are going
Dr.
to start.
Ashwini, just one last
Yeah.
5 o'clock sir we still have 4 minutes
Yeah.
one last point Dr. Ashwini in case during the presentation if this slide gets stuck up you can then press the option and the next वो right click करेंगे तो एक next का option आता है तो उससे
अच्छा.
you can click the next and slides will again start moving it rarely happens but कभी होगा तो this is a thing you just have to remember
Okay. Will do.
Dr. Indranil you can put up your intro slide now we have
Yes.
4 minutes to go
Yeah, but we can do that. In the meantime, before doing that, we can talk with Dr. Bharadwaj and Dr. Mehta regarding the flow of the events. So I'll be the moderator for today's program. Dr. Bharadwaj, I'm Dr. Indranil. So we'll start with the introduction. So I'll present the introduction slides and the agenda. And after that, we'll go to Dr. Mehta's presentation, beta blockers in heart failure and hypertension.
Okay.
And after the presentation, then we'll go directly to your presentation.
Okay.
So your presentation will be on young hypertensives. So once both the presentations finish, then we'll go to the panel discussion. So we'll ask questions one by one. We'll ask Dr. Mehta questions, then we'll ask you questions. You can discuss between yourselves, add to each other's answers as well.
Yeah, sure.
And we'll take some audience questions as well if time permits.
How many people in the audience are there?
Nearly there will be 1,000 people. They will try to log in at least 1,000. Some of the programs are 600, 700. Saturday you can be 900,000, even more. It depends on how the login. So we'll also share the numbers with you during the course of the program. So what are the logins?
It's all across India?
Yeah, across India. Mostly in the north, but other regions will also join. But
Sir,
mostly in the north, I
in
think.
But the invitation has gone pan-India through our entire
Pan-India.
field force. Yes.
Yes.
That's it.
So average is 1,000.
Okay.
So the entire program will be 1.5 hours total.
Mm-hmm.
So we'll start at 5. So we'll finish around 6:30, hopefully.
Okay.
So I'll share my screen now. Go to the introduction slides.
Okay.
So Dr. Mehta, we'll start with the introduction slides, and then we'll go to your presentation, then Dr. Bharadwaj's presentation, then we'll go to the panel discussion.
Sure.
Mr. Sandeep, just let Dr. Indranil know when he has to start. They have already had the discussion.
Yeah, yeah. Yes, yes.
Hello.
Recording has started.
Hello.
Recording has started.
निशान जरा दूसरे वाला भी ऑन कर.
Sir, you can start now, Dr. Indranil.
Okay, you all can unmute, mute your speaker phones, then I can start. Okay. Good evening, everybody. Welcome to Experts Outlook live webinar series. I am Dr. Indranil Purkait, General Manager, Medical Services, Ipca Laboratories. Welcome you all to this live webinar. Today, we have a very interesting topic, hypertension and heart failure, and we have two important and eminent speakers from North India who will join us and take us through the different aspects of the hypertension management and heart failure. Now, let us introduce the speakers one by one. First, I would like to welcome and introduce Dr. Ashwini Mehta. He is an MD in Internal Medicine, DM in Cardiology. He is a Senior Interventional Cardiologist at Gangaram Hospital, Delhi. His main specialties and his areas of interest include advanced heart failure and transplant cardiology, cardiovascular disease, clinical cardiac electrophysiology, congenital cardiac surgery. He has many sub-publications in national and international journals to his credit. I welcome Dr. Ashwini Mehta, sir, to today's program. Next, I would like to welcome and introduce Dr. Saket Bharadwaj. He is an MD in Internal Medicine, DM in Cardiology, Fellow of American College of Cardiology, European Society of Cardiology. He is presently the Senior Interventional Cardiologist and the Director, Cath Lab and Head of Cardiology, Multispecialty Mata Chanan Devi Hospital, New Delhi. He has been practicing as a Senior Interventional Cardiologist of Delhi for many years after doing DM Cardiology from GB Pant Hospital in 1996. He has a large experience in coronary intervention and has a large number of research papers in national and international journals to his credit. He also visits BL Kapoor and Agarsen Hospital, Delhi. He is an eminent speaker as well. So let us welcome Dr. Saket Bharadwaj to today's program. Now, let us go through what are the topics which are there for discussion. Topic number 1, beta blockers in heart failure and hypertension. The speaker is Dr. Ashwini Mehta. Topic number 2, diagnosis and treatment in young hypertensives, which is becoming young hypertensives are becoming an area of concern nowadays, and Dr. Saket Bharadwaj will shed more light on this issue. After these two presentations, we'll have an interesting panel discussion where the two speakers will talk about different aspects and answer all our queries from all our audiences and for the panels as well. So with that, I will hand over the stage to Dr. Ashwini Mehta to take us to the first presentation, beta blockers in hypertension and heart failure. Over to you, sir.
Thank you, Dr. Indranil, for the introduction. And I'll be talking about the beta blockers and their role. I'll also be speaking about heart failure, where do they stand, and would also be giving some evidence about the use of beta blocker in hypertension. So if we, first of all, let's look at hypertension. If we look at hypertension, we all know very commonly we say it's a silent killer. Now, why do we say it's a silent killer? Because we all know that lifestyle associated diseases are rapidly rising, and it's been a leading cause of death worldwide since last 2 decades and will continue to be so for many, many more decades to come. If we look at these non-communicable diseases, most of them are related to hypertension directly or indirectly, like hypertension per se, or coronary artery disease, or cerebrovascular strokes, or heart failure.
Sir, sorry to interrupt, sir. Have you put the PPT?
Yeah,
We cannot see
Dr.
the PPT,
Ashwini,
sir.
can you share the PPT?
yeah, I'm already
Have you
sharing.
shared the PPT?
Yeah, I'm already sharing.
Sir, can you share it again?
I'll do it again, just a moment.
Sir, it is not.
Let me.
Yeah, please do it.
Are you able to see my screen? Are you able to see my screen?
Can you
Yes,
just
sir.
minimize?
You can minimize this and go to the.
Can you minimize?
I will. Are you able to see that?
Sand dunes.
Yes,
Yes.
sir.
Sand dunes. Yeah. Fine. So I'll just read. Is it okay? Are you
Yes,
able
now
to see
we
my
Yes, sir.
slide?
Yeah,
see.
now we are able to see.
Okay.
Yes.
So my talk today is going to be about beta blockers, hypertension, and heart failure. And I've already just now talked that hypertension is known as silent killer, and rightly so, because hypertension directly or indirectly by coronary artery disease or through strokes or through heart failure is the major reason and a big global burden. And when we say global burden per se, it directly causes also lots of issues. But then hypertension is a global burden because it's estimated that about 1.5 billion people worldwide by 2025 would be having hypertension. And we all know that hypertension is a major risk factor for cardiovascular diseases. And if you look at patients who have coronary artery disease and coming with myocardial infarction, about 69% of these patients already have hypertension. So even for coronary artery disease, this is one of the biggest risk factors. Now, if you look at the cerebrovascular accident, strokes, so it is even more than the coronary artery disease. About 77% of patients who have first stroke have history of hypertension. And similarly, patients with heart failure who have chronic heart failure, in about 74% patients, they have hypertension. Now, it just not causes increase in coronary artery disease, cerebrovascular strokes, heart failure, but also surprisingly, like diabetes, it is also a huge risk factor for peripheral arterial disease. And we all know that as the age advances, the incidence of hypertension increases, and mainly the hypertension which increases in elderly is the systolic hypertension. And the isolated systolic hypertension is very common in elderly people, and that is also needs to be treated very, very aggressively. Now, given this dreadful scenario of hypertension and it being a huge problem all over the world, more so in our country where patients are not properly controlled with hypertension, we also know that if we treat hypertension, the benefits are tremendous. The benefits cut across various things, like you do see reduction in incidence of coronary artery disease, you do see reduction in strokes, you do see reduction in heart failure, you do see reduction in peripheral arterial disease, you do see reduction in kidney disease as well. So just by controlling hypertension, you're able to take care of a lot of problems. And this is very interesting that if you just reduce blood pressure just by 2 millimeter of systolic blood pressure, you see a 10% reduction in stroke mortality, which is huge, and also a 7% reduction in risk of ischemic heart disease mortality. So even small reductions in blood pressure bring about great changes in morbidity and mortality, not just of coronary artery disease, but also of stroke. One of the cornerstones of therapy of hypertension worldwide, right from the beginning of treatment of hypertension, after diuretics have been beta blockers. And the beta blockers in the earlier JNC classifications were the first line drugs. But in present scenario, all the guidelines do not recommend beta blockers as a first line drug to be used. ACE, ARBs, they are the drugs which are most commonly used, and rightly so. And also the calcium channel blockers in many patients. But beta blockers can be used in hypertension, specifically when the hypertension is complicated, especially those who have history of coronary artery disease, patients who have had myocardial infarction, or patients who continue to have angina, and also in patients who have heart failure. You can't treat heart failure, coronary artery disease and hypertension without the use of beta blockers. And similarly, patients who have complicated hypertension also needs to be given beta blockers. Even in the younger people who are young, who have high sympathetic drives, these days we see a lot of young executives in pressure situations, and when we need to treat them, we can't treat them alone with other antihypertensives. We need to give them beta blockers also. The journey of beta blockers has been very long. Initially, the beta blockers which were discovered were non-selective beta blockers, and in the first part of the 20th century, the beta blocker concept started to come into being, and it was mainly in 1962, propranolol was synthesized, and this propranolol was started to be used in hypertension in late 60s and early 70s. Atenolol came later on in 1968, and then these two drugs, propranolol and atenolol, continued to be used for hypertension and heart disease for a very long time. And in 1988, one of the persons who worked on beta blocker, who researched on beta blocker, Sir James Black, he got the Nobel Prize for that. But now, from this era, the beta blockers have moved. Today we have modern beta blockers which are highly beta 1 selective and have much less side effects, and a lot of problems which have been associated with beta blockers, and some of them many people have debated. The reasons why beta blockers have been pushed out of various guidelines have been because of meta-analysis, and most of these meta-analyses were not done on the modern beta blocker, which are more highly beta 1 selective beta blockers, and they were done on beta blockers like propranolol or atenolol mainly. But the newer beta blockers like metoprolol, bisoprolol, nebivolol, they all are probably different. And why they are different? Because they are highly beta 1 specific. And what we know, that if we are looking at antihypertensive drug, what we want is that the ideal drug should be able to reduce mean arterial pressure, it should be able to reduce total peripheral resistance, it should have no effect on cardiac output, it should decrease the heart rate, the sympathetic nervous system should be, the activation of sympathetic nervous system should be reduced, the RAS system activation should also be reduced. This is what we are looking from an ideal antihypertensive drug. And the traditional beta blockers mainly took care of all the things except the two. They reduce the cardiac output and also increase the total peripheral resistance. So given this in background, although this advent of beta blocker was a huge change at that time in 60s and 70s of therapy area, but then as the decades have evolved, we have come to know that beta blockers, which are highly specific, they need to be used. And if we look at metoprolol, which is the most widely preferred beta blocker in our country, what we know that metoprolol does have a good effect on blood pressure. It does reduce systolic and diastolic blood pressure in patients. We all use it in our day-to-day practice, and we know that beta blockers alone or in combination with other drugs such as calcium channel blockers, the ACE inhibitors, the ARB, they are able to reduce blood pressures very effectively. And a large number of our patients are on combinations of these drugs for decades together, and they are so comfortable with that so many times doctors are also reluctant to change them. And even if we change them, patients are also not wanting to change their original drugs, the combinations of beta blocker plus calcium channel blockers mainly are such. And what we know that when we use a combination, close to about 45%, up to 30 to 45% patients, they achieve their goal with various combinations. So that is quite a remarkable thing which is achieved with beta blockers as far as treatment of hypertension is concerned. We also know that in the UK PDS study, it is a very interesting finding. This is a very controversial thing, but it did show that the mortality reduction in diabetic hypertensive in UK PDS in 10 years follow-up as compared to ACE inhibitors, the beta blockers had a much greater reduction, death from any cause. This is about 23% reduction, which was seen, and this has been published in New England Journal of Medicine in 2008. So beta blockers, as far as management of hypertension in patients with stable ischemic heart disease is concerned, that we do know that their goals are to reduce blood pressure to less than 180 with a guideline directed good beta blocker, ACE inhibitor or ARB, which is the class 1 indication. And if the BP goal is not met and the angina pectoris continue to occur, so we can add a calcium channel blocker, or we can even add a dihydropyr CCB or a thiazide type diuretics or an MRA if in such patients the blood pressure is not controlled. So in patients of stable ischemic heart disease, we need to treat hypertension with beta blockers in combination with other drugs. The utility of beta blockers in the whole spectrum of hypertension, which is complicated by coronary artery disease, whether it is post myocardial infarction, whether it is angina, or whether it is congestive heart failure, or whether it is arrhythmia, there is a huge scope, need, and also guideline directions which favor the use of beta blocker. And beta blockers should be used in such patients who are either post myocardial infarction or who continue to have angina, arrhythmias, or congestive heart failure. But in patients who are not having complicated hypertension, beta blockers should not be used as a first line. But in patients with uncontrolled hypertension and who are on various other antihypertensive agents and those with complicated hypertension, beta blockers should be considered in treatment, specifically if these patients have congestive heart failure or have arrhythmias or if continue to have angina. So, as far as the utility of beta blockers in complicated hypertension is concerned, the initial therapy recommended is ACE or ARB, calcium channel blocker or a diuretic, and the step 2 could be a triple combination. And the resistant hypertension, if it is there, we should consider adding spironolactone or other diuretic, alpha blocker or a beta blocker. And we should consider beta blocker at any treatment step where there is a specific indication for their use. For example, heart failure, post-MI angina, atrial fibrillation, or younger women. So in these particular patients, we should consider use of beta blocker. There is also a role of alpha and beta blocker labetalol use in pregnant patients also. So beta blockers should be used in hypertension as and when indicated, and there has been a lot of interest which has come back again in beta blockers, specifically in therapy areas of hypertension, more so in younger people, more so in patients who are complete. Now, as far as heart failure is concerned, heart failure is a very complex etiology. Heart failure is mainly a clinical diagnosis and which is supplemented by various clinical signs and symptoms. And if we have to confirm heart failure, we can make use of the biomarkers such as NT-proBNP. Now, what all leads to heart failure? There are certain risk factors which predispose to heart failure. The first one being the cardiac problems themselves, whether it's a valvular disease or a rhythm disorder or a cardiac muscle disorder or coronary artery disease, which per se can cause reduction in the cardiac output and reduction in the ejection fraction of the heart, leading to HFrEF and heart failure. There could be lifestyle related issues like the diet related issues, excessive salt and water, the drug or alcohol misuse, which itself can cause heart failure. Certain infections can lead to heart failure, rheumatic heart disease leading to valvular dysfunction, and also some rare diseases causing myocarditis. And of late, even with COVID-19, there have been reports of myocarditis and acute heart failure. So all these infections also lead to heart failure. Many times the left-sided heart failure comes as secondary to right-sided heart failure, which in turn is because of the lung pathology, either the pulmonary artery hypertension or COPD or long-standing lung issues. Similarly, severe anemia, kidney disease, diabetes, obesity, thyroid disorders, these all can lead to heart failure. But one very big, easily treatable cause of heart failure, which is ignored all over the world and which can be really treated very well, is hypertension. Hypertension is also one of the very important causes, and the Framingham heart study noted that in 1 in 5 hypertensive will develop heart failure in absence of myocardial infarction. So that is something which is huge. The risk factors for heart failure are also increased sympathetic overactivity and the effect of different adrenergic receptor activation. In heart failure has been proposed. There is beta-1 adrenergic receptor mediated activity, beta-2 and alpha-1, which all can cause various deleterious effects on heart, ranging from tachycardias, induction of myocardial hypertrophy, renin release and stimulation, tachyarrhythmias, sodium and water retention. They all can lead to congestive heart failure ultimately, and mainly it is mediated to beta-1, beta-2 and alpha-1 adrenergic receptors. The progression of hypertension to HFrEF or HFpEF is also not uncommon, and what we know today that uncontrolled hypertension can affect heart in two ways. It can either cause a concentric myocardial hypertrophy causing HFpEF, or it can cause coronary artery disease or other myocardial insult leading to left ventricular dysfunction due to eccentric hypertrophy, loss of myocardial function, and this can lead to HFrEF. So hypertension leads both to HFpEF, which is heart failure with preserved ejection fraction, and also heart failure with reduced ejection fraction. There is also a terminology which is the mid-range, and I would not like to confuse you with that, but what we know today that for HFrEF, the first-line drugs, among the first-line drugs, beta blocker is one of the most important drugs which needs to be given, and the importance of beta blocker in treatment of heart failure due to reduced ejection fraction is very, very important. And this one single drug shows a significant improvement in heart failure and even causes left ventricular remodeling, leading to better outcomes. Regarding HFpEF, the role of beta blocker is still clouded. We're not sure. Patients with atrial fibrillation with fast rate do require beta blocker who have HFpEF, but there is no trial, there is no scientific documentation today to say that beta blockers work in HFpEF. Recently, the trial with ARNI has shown that it might be effective, and specifically those HFpEF patients who are more likely to be having little on the reduced side. So, given this background, there is a role of beta blockers also in HFpEF, but mainly it is in HFpEF as of now. The effect of beta blockers in heart failure is basically the neurohormonal action, which is reduction in the direct sympathetic effects on the myocardium, and which can lead to decrease in the arrhythmias. It can also lead to decreased amount of stimulation of the heart and even reduction in the sudden cardiac death. Then there are certain hemodynamic effects such as the heart rate lowering effect, and also it can lead to restoration of beta receptor responsiveness. So effects of beta blocker in heart failure are quite significant. Now if we look at the beta 1 selectivity of various drugs which are used in heart failure, what we know that the earlier beta blockers such as propranolol, they were non-selective. But if we look at the beta 1 selectivity, right from metoprolol, atenolol, bisoprolol, they are all beta 1 selective drug, with bisoprolol having a significant amount of beta 1 selectivity. And if we look in the use in heart failure, we know that the beta 1 selective blockers are the usual drugs in heart failure. They are the drugs which are used in heart failure therapy. One word about alpha and beta blockers. The carvedilol is the drug which has been shown to be effective, and it has a role in anti-remodeling effects, and it reduces the progression of heart failure along with beta 1 selective blockers. We have a lot of evidence regarding use of beta blockers in heart failure. I need not go into detail whether patients are having diabetes or not, whether patients are on ACE inhibitors or not, in elderly, in diabetics, in patients with low ejection fraction, in women. So all over, you do see that patients who are given beta blockers, they do well. And in this particular slide, you clearly see the hazard ratios favoring that beta blocker is better in number of studies which have been done. So what do the guidelines say? The Indian Guidelines on Hypertension, which was published in 2019, clearly said that selective beta blockers such as metoprolol, bisoprolol, and alpha beta blockers like carvedilol may be used in patients with congestive heart failure, stabilized with ACE inhibitors and diuretics. And the ACC-AHA guidelines of 2017 also talks about use of beta blockers for heart failure with preserved ejection fraction, and it has put it as 2A and the level of evidence as C. The use of beta blocker agents, ACE inhibitors, ARBs in patients with hypertension, it is specifically those who have HFpEF with hypertension. So this is the recommendation level in HFpEF. The 2016 guidelines, European guidelines, they do say that beta blockers in heart failure with reduced ejection fraction, it is class 1B. The beta blocker is recommended with asymptomatic left ventricular systolic dysfunction with history of myocardial infarction in order to prevent or delay the onset of heart failure or prolong life. This is one indication where it is of great use, and also the another indication that beta blocker is recommended in addition to ACE inhibitor for patients with stable symptomatic HFrEF to reduce the risk of heart failure, hospitalization and death, and the indication is class 1A. So we know that beta blockers are firmly established in HFrEF, and it is the main therapy area for beta blockers today. Just to summarize, we know that heart failure and hypertension are major causes of cardiovascular disease. Beta blockers are useful in complicated hypertension, specifically those who have angina or who are post-myocardial infarction. Beta blockers are important regime in treating heart failure and have proved to be useful in reducing the likelihood of progression through the continuum of congestive heart failure They should be included in the therapeutic regimens of patients with asymptomatic left ventricular dysfunction to prevent progression to symptomatic heart failure and to improve the survival. The evidence-based beta blocker therapy, which is bisoprolol, carvedilol, and metoprolol, is the mainstay of treatment in all symptomatic patients with hypertension and heart failure. So this is something very important, that not all beta blockers are same. It is the highly beta-1 selective blockers, such as bisoprolol, metoprolol, which are mainly being explored in areas like coronary artery disease and heart failure and hypertension, and also the carvedilol, which is the mainstay of treatment, and try to avoid the non-selective beta blockers and also atenolol because of so many related issues. Thank you so much for your kind attention.
Thank you, Dr. Mehta, for your wonderful presentation. We'll come back to you during the panel discussion. We have a few questions for you. So in the meantime, let us go to Dr. Bhardwaj for his presentation, Diagnosis and Treatment of Young Hypertensives.
Good evening, friends. My topic is, let me share this thing first.
You have to share the screen. Yeah.
Yeah. Hypertension in young patients.
Your voice is a little bit low, sir. Your voice is coming a little bit low.
Okay. Is it better?
Yeah, it is better.
Hypertension in young population. Yeah, this slide is, I think, same. It was same in Ashwini's also. We can see that hypertension is the leading risk factor for death and disability world over. At any point of time, 1/4 of world population is suffering from hypertension. That's a very large figure. You can see here that it's a leading risk factor for mortality and morbidity worldwide. Out of the various list of various diseases, it's at the top. And mind you, it is modifiable. So another important factor. Of late, we have seen that hypertension is increasingly seen in younger population. It's coming to an epidemic proportion in younger people. In this study in India, you can see that one in every 5 young Indians is suffering from hypertension, and their treatment is grossly they are grossly undertreated. That's a huge figure. If we are suffering at this level and there is very inadequate treatment, I can tell you, we can predict that in years to come there will be epidemic or explosion of cases of cerebrovascular disease, coronary artery disease, or kidney disease. So we should be very aggressive on that front. Just to give a brief about this thing, that hypertension is in young is classified into 2: primary hypertension and secondary hypertension. Primary hypertension when there is no obvious cause of hypertension. It's also called essential hypertension, and it accounts for about 90% of the patients of young hypertensive patients. And secondary hypertension when you have an obvious cause. And what are the factors which are associated with young hypertensive patients? We can see that these people generally have family history. They have very sedentary lifestyle. They are diabetic. They are obese. They have metabolic syndrome. Their salt intake could be high. Frequent consumption of junk food. Use of illicit drugs. Psychiatric conditions may be associated. And few studies have shown that the kids who are the young adults who had low birth weight, they also are likely to have hypertension in young adult. Another factor like hyperuricemia has also been shown to be associated with, in one of the studies, that it could lead to hypertension in young adults. Then how about secondary hypertension? What are the causes? We all know renovascular, which can be renal parenchymal disease, renal vascular disease, endocrine, hyper and hypothyroidism, Cushing syndrome, phaeochrocytoma, primary aldosteronism, hyperparathyroidism, acromegaly, cognition of aorta, obstructive sleep apnea. There are few other rare causes also which I have not covered. If you look at the incidence of the prevalence of hypertension in secondary hypertension in young adults, it's very less. You can see that if you take the total number of hypertensive patients, the hypothyroidism, which is maximum in these, it is 1.9%. Similarly, renal vascular 1.7, renal insufficiency 1.5%. So numbers are very less. So most of the time we see in our practice are patients of essential hypertension who are young. Just to go over briefly about hypertension, the cardiac effects are it leads to left ventricular hypertrophy, increased wall stress, and there is increased wall thickness. It leads to higher mean pulse pressure, higher stroke volume index, and higher total peripheral resistance index. You can very clearly see that the hypertension leads to increased cardiovascular mortality and morbidity. You can see elevated blood pressure and stage 1 hypertension. It is significantly, they have higher incidence of cardiovascular complication, and with stage 2 hypertension, it's grossly more. How about pathophysiological features? This is one of the diagram in which they have shown that in early stage there is some thickening of media, and silently it increases. It goes to more or less covering 80% of the arterial lumen. So small and large arteries are affected in this way. This is particularly for small and medium-sized arteries. For large arteries, their wall becomes stiff. I will be showing it. This is for small arteries. You can see that vascular media thickening leads to reduction in the lumen, which in turn leads to increased blood pressure and increased vascular resistance, and it's a vicious cycle. Same way with large arteries, the elastic fibers are damaged there, leading to stiffening of coronary arteries, leading to progressive systolic high blood pressure, and further it's again a vicious cycle leading to end organ damage and other features of full-blown hypertension. So very important that hypertension, we all know, as Dr. Ashwin also mentioned, it's a silent killer. So these changes which I mentioned, these go on silently in the background. Many people don't detect it till they get into one of the end organ damage, and result that you have kidney damage, you have heart damage in the form of left ventricular hypertrophy, that there could be cerebrovascular accidents and a number of changes. So very important that we should detect this subclinical disease, which remains subclinical to large until we detect it. This is one of the slides which shows that increased stroke volume and aortic stiffness contributes to isolated systolic hypertension in young hypertensive patients. Another one important factor which Dr. Ashwini also mentioned, that increased sympathetic tone. This has a cascading effect and leads to insulin resistance, elevated renin-angiotensin system levels, then vasoconstriction and thrombogenic, prothrombogenic milieu, and further on, due to effects of all these, it can lead to end organ damage, atherosclerosis, endothelial dysfunction, and these ultimately lead to organ damage. If we come to clinical features, most of the patients are asymptomatic. Many of them are incidentally detected to be hypertensive when they come for something else. Few of them come with hypertensive emergency like malignant hypertension, CHF, sometimes stroke. And many of these patients are diagnosed in screening. And it's been said that, or maybe it's recommended that we should use opportunistic screening wherever possible to diagnose these patients, because many of them are asymptomatic, and if you don't diagnose them timely, they will come up with various complications. So screening, opportunistic screening in whatever form, should be promoted in this. Historically, we should look for diabetes, premature coronary artery disease. We should ask for whether the patient is using oral contraceptive pills, alcohol, tobacco products, methamphetamine. This is also called KIT, and this leads to chronic hypertension with renal damage, and hypertension is very aggressive patients who are taking methamphetamine. Now, next for BP measurement, all of us know that we should be measuring blood pressure in the way the guidelines are there. It should be in sitting posture at level of the heart, EP instrument, though all those things are there. But very important in young people that we should have frequent measurements. That's very important because many times it could be misdiagnosed. It can be overdiagnosed or underdiagnosed. And to overcome that, out of hospital measurements and maybe ambulatory measurements, they can be used because that way we can obviate the need for, obviate the effect of white coat hypertension. By using these modalities, sometime in young people, we can take care of white coat hypertension and we can diagnose correctly whether the person is suffering from hypertension. Examination mainly looks at two things in young patients. First, whether there is any target organ damage, because people who have target organ damage at the first instant, they are in the advanced stage. We should be very aggressive with pharmacotherapy in these patients. So we should look for various features, which I will be telling later. And then features of secondary hypertension. If there is secondary hypertension, then these patients have potential for cure. You can really cure them, and you can give them very specific treatment, and which will be able to control blood pressure in a very reliable way. And the features which we look for in this patient examination is we should look for whether these patients are overweight, they have waist circumference increased, whether they have features of insulin resistance, then we should look for urinary examination for proteins and blood, LV epics to look at whether they have left ventricular hypertrophy, fundoscopy for features of hypertension in the retinal arteries. Features of secondary hypertension, we should look for pulse discrepancies, which could be because of vasculopathy such as tachycardia arteritis, radiofemoral delay. This is indicator of coarctation of aorta, abdominal bruit for renal artery stenosis, flushing, sweating, and tachycardia points towards pheochromocytoma. Acne, striae, and moon phases points towards Cushing syndrome, and during examination look at the renal cause. Then we come to laboratory investigations. Commonly, these are the investigations which you routinely do in hypertensive patients, and they have some leads there, like 12-lead ECGs for left ventricular hypertrophy. Serum creatinine is to look for renal cause. Potassium is for hyperaldosteronism. Then sugar and those things to look at the cardiovascular risk in these patients, which ultimately guides the treatment. Then do we need to do investigations for secondary hypertension in all patients? No, it will be very costly, it will be time consuming. We should suspect whether a person has secondary hypertension, and these are the predictors of secondary hypertension. If age is less than 30 and there is no other risk factor, we should suspect it. Patients of resistant hypertension, patients who have sudden deterioration of blood pressure, people who have target organ damage at young age, we should look for, because these patients are likely to have secondary hypertension. Then clinical features, which I will be telling, and investigation, which should be there, which will guide you to look for secondary hypertension. And if on ABPM there is non-dipping pattern of blood pressure, that's also in young people suggests secondary hypertension. Specific tests. These tests are just theoretical. I will talk to them, but basically, there is a battery of tests, and you have to do particular tests depending upon your clinical suspicion, like plasma renin and aldosterone for hyperaldosteronism, urinary catecholamines for pheochromocytoma, renal sonography for suspected renal disease, CT scan and ultrasound for renal artery stenosis, and urinary screening for amphetamines and cocaine in case the person is addicted to those drugs. Similarly, GGT for its a marker of oxidative stress, and C-reactive protein marker of inflammation. These are general tests. These tell about the milieu of the young hypertensive, whether he has inflammatory pathology inside or oxidative state. These are general tests. They don't guide you in a specific direction, but they tell you that person has a bad milieu. Now, then we come to management strategies. Let me tell you, in older people, in hypertensive patients, our main way of managing the patient is that we calculate 10-year cardiovascular risk based on various risk factors. However, same is not true for young hypertensive, because these patients have low risk. Despite risk factors, various risk factors, their 10-year risk is low. Though lifetime risk may be more, but 10-year risk is low. So dominantly going on the basis of risk factors, we cannot treat these patients. So these are treated a bit differently. There is another important ambiguity in managing these patients with hypertension. There's not many data which talks about young people who are managed with antihypertension therapy, and then they are, how much is the benefit. There's not much data on this. Few studies are there. This is one of the studies which says that there's 29% reduction in major adverse cardiovascular events, 33% reduction in cardiovascular mortality, and 37% reduction in heart failure. This is one of the studies, but there's not too much of data. So many people, there are two schools of thought that young people may not be needing that aggressive management of hypertension. Lifestyle is the only way of managing these patients, and you can add if required. So those two schools of thoughts are there, but still, let me tell you, this is a very important slide. Here you can see that they have given various, this is in young people, they are given various levels of hypertension. ACC, these people revised their old this classification, and they are given on the basis of a few set of studies which include SPRINT study. On that, they brought down the blood pressure levels from 140/90 to 130/80. So stage 1 now, according to this, is 130/80, whereas in rest of the European studies and NICE, they are still hypertension is higher. The reason being is that there were very few, the population of young people in the studies which they have considered in ACC was very less. They were underrepresented. So they were not sure whether these will validate, these levels will be validating in young people. So that's why European and NICE guidelines are still sticking to the old, whereas American ACC guidelines, they say that stage 1 is 130/80 and stage 2 is more than 140/90 and stage 2 and 3 and so on. So because of this, the treatment, this treatment is dominantly recommended on the basis of those guidelines, that you should not be treating all hypertensive, young hypertensive whose BP is more than 130/80. They should only be treating if their blood pressure is more than 140/90. This is general recommendation. That is, by ACC, it is class 2 people who have stage 2 hypertension, they should be treated, and that will be stage 1 in European and NICE guidelines. If they have chronic kidney disease, proteinuria, then their goals will be lower, 130/80. And ADA, however, says that if they are diabetic, then their levels should be 130/80. These are, if they have, we all know, if they have comorbidities, definitely their goals should be, it should be less than 130/80, like diabetes, chronic kidney disease, heart failure, stable ischemic heart disease, secondary stroke prevention. That is, in that it's more than 140, then peripheral arterial disease, again 130/80. And if you come to life, the
your voice is very low. Yeah. Your voice is a little bit low, Dr. Bhardwaj. So
I don't know.
yeah. Now
Is it better?
Yeah, now it's not better.
Okay. So these are the various lifestyle changes, and lifestyle changes must take a bigger place in the management of young hypertensive patients, and particularly by European guidelines. They say it should be managed through lifestyle modification. This is not enough data. Our recommendation is by ACC guideline, you should be treating. Then comes pharmacological therapy. On pharmacological therapy also, in this also, there is some difference in European and American, like the European guidelines and European guidelines, that is nice. The people in America and Europe, they generally say that all drugs, whether it's beta blockers, whether it is angiotensin blockers, whether it is ACE inhibitors, whether it is calcium channel blockers, they are same as far as treatment of hypertension. However, only NICE guidelines say that in people who are less than 50 years, their ACE inhibitors, angiotensin blocker, and beta blocker, they should be given first priority. That there were 2 studies on that, and on those basis they have recommended that. So we can take that, and in our guidelines generally we follow that is less than 50 young people we should be using these drugs. That is, young subjects we should be using angiotensin as first step as angiotensin converting enzyme inhibitors or angiotensin blockers, or beta blockers we can use, and step 2, 3 we can use other drugs. And obviously if they have, as Dr. Ashwini also pointed out, if they have other comorbidities, then we should be using, like for diabetes, ACE inhibitors and ARBs are drug of choice, as for drug of first choice. Similarly, kidney disease, ACE inhibitors, they modify the disease also. Coronary disease, beta blockers come in forefront. Stroke again, ACE inhibitors and ARBs. Heart failure, beta blocker again and ACE inhibitors again. Then come diuretics and potassium channel blockers. I think it's again the repetition of the same. Then approach to, it's general overall this thing, approach to the young hypertensive patients. Obviously, if they have secondary hypertension, we should detect it and treat the cause. If it is essential hypertension, that is primary hypertension, there is no comorbidities. Stress is again on lifestyle therapy. Dominantly, if it is there are comorbidities like diabetes, CKD, CAD, heart failure, our levels are down 130/80. We should be treating it till that levels. And next, we add drugs accordingly, as I mentioned. Drugs should be added if BPs are high according to the levels. I think that should be the summary. Hypertension in the young is increasing in prevalence. Evolution of secondary causes of hypertension in each young individual is necessary. A thorough history and clinical examination is vital to get clues for secondary hypertension. Assessment of renal parenchymal and vascular disease should be individualized. And lifestyle therapy remains cornerstone in the management of hypertension in young people. A goal of 140/90 millimeter is recommended for hypertension without morbidities. With morbidities, 130/80. ACE inhibitors, ARBs come as first line. Calcium channel, thiazide diuretics, beta blockers, they are used, particularly if they are comorbidities. Thank you.
Thank you, Dr. Bhardwaj, for your wonderful presentation. So now we can have the panel discussion. We have some questions for both of you. So first we'll go to Dr. Ashwini Mehta. Dr. Mehta.
बिल्कुल चल ठीक है मैं अभी मिलता हूँ तुझसे ठीक है
Dr. Mehta?
Yes.
Yeah. Okay, Dr. Mehta, the first question for today is for you.
Yeah.
Can you hear me?
I can hear you clear and loud.
Yes. So your presentation was on hypertension and heart failure and the role of beta blockers in that. So first we'll start with the heart failure and hypertension. So in a patient who is hypertensive and who is uncontrolled, so generally the heart failure develops depending on the duration. Is it more related to the duration of uncontrolled hypertension, or is it related to the quantum of uncontrolled hypertension?
Well, this is a very good question, and in fact we know that as the duration of hypertension increases, the heart failure increases, and we also know that the patients who are severely hypertension, heart failure in fact increases with both.
Okay. Now coming back to the quantum, we had a Mumbai cohort study which was done in lakhs of patients, and which actually found that the blood pressure, the systolic, if it is increasing from a range of 120 to 130 to 140, so even if the quantum it is not increasing beyond 140, still there is increased risk of MI and stroke. So if we have generally, generally we see that the patients who are in the range of 130 to 140 never take any treatment unless they have a risk factor. So are these patients also prone to develop heart failure if this left for like 10 years, 15 years, like in this stage?
Well, this is a very good question, and now we are absolutely clear that there is a linear correlation, and that if you go down with the blood pressure control, the complication rates are less. And that is the reason that after every few years there is a downward revision of hypertension treatment goals. And similarly, we know that patients who are having stage 1 hypertension or even having a little lower degrees of hypertension, if we treat them, and there was a data from Sprint also which talked about reduced morbidity mortality, and it did talk of reduction in the incidence of various complications, and I think heart failure would also mirror that easily. And we also have evidence from Framingham study, and this is very interesting evidence that patient of hypertension, specifically what it talked was that all patients of hypertension, 1 in 5 had a lifetime risk of developing heart failure. And not just that, if the patient, even in absence of myocardial infarction, what we know is that 1 in 9 males and 1 in 6 females would develop heart failure, which is quite significant. So treating hypertension even to the lower levels, even the levels you mentioned like in the Mumbai cohort study,
Yes.
to reducing the blood pressure further low, it does help.
Okay. So now in your presentation we had heard 3 terms. We had heart failure with preserved ejection fraction, medium reduced ejection fraction, and reduced ejection fraction. So in this patients of hypertension, which type of heart failure is predominant, or is it such that the reduced preserved develops first and then it transitions into reduced ejection fraction? So what is the sequelae or the course of heart failure?
You know, heart failure, like I said, is mainly a clinical diagnosis. And what we mean by saying that it's a clinical diagnosis is that all the patients who are diagnosed to be having heart failure, these patients are mainly diagnosed on the basis of clinical basis, and so many times you would require cardiac biomarkers also for that. So having said that, I also know that many patients who have heart failure, what we know earlier, we were only picking up heart failure with reduced ejection fraction. The incidence of all the registries which are there, they do talk that in HFrEF, as far as concerned in India, about 60 to 70% patients have HFrEF and 20 to 30% patients have HFpEF. But the incidence of HFpEF has been rising, and the incidence of HFpEF is more in elderly patients, patients who are female, in hypertension, in atrial fibrillation, in diabetes, but it is lower in coronary artery disease where the HFrEF is more. The incidence of HFrEF and HFpEF both is roughly in many studies equal also. But in our country, the registries show 60 to 70% HFrEF, rest HFpEF. And definitely when there is HFpEF, a large number of them are not diagnosed. So in reality, it could be much different. In reality, it could be equal amount of HFrEF and HFpEF patients.
Okay, I mean that's a very important standpoint we got from you today. I mean we have not heard from, and I mean like this, something like this. So you are saying that actually it might be equal. So that's a very important point. So going to Dr. Bhardwaj, sir, your presentation was on diagnosis and treatment of young hypertensives, and in India we can see there are a lot of young hypertensives which actually are coming forward. So in your practice, how young have you seen these patients coming to you for treatment?
I have seen patients up to the age of 15 also. 2-3 patients who are in the range of 15 to 20. Otherwise, most of the patients, the maximum number is between 30 to 40. That's the maximum range. But as young as 15 to 20, I have seen.
Okay. So in this 15 to 20 patients, are they secondary hypertensive, or they're primary?
Both of them were secondary hypertension. Yeah, secondary.
Okay. So now, because the young hypertension is increasing, how do you see we tackle this menace? So should we start community screening? We already do. There are programs in corporates where there is regular health camps. But what other things can be done to screen them?
Like community screening will be a very effective modality, but there will be lots of commitment to that, and it won't be, I don't know whether it will be cost effective. The word over, the best way is to opportunistic screening, like in school. You can have at the time of maybe at the 12th or 11th of that time school leaving or something, or in between, you can have hypertension. You can check their blood pressure. That is the best way. So screening at the time of some opportunity where you see these young people, maybe it's college entry, that time you can see. So that is the recommended strategy word over at present. Community, like you cannot screen like whole city or something. That will be a tough thing, but you can do it this way.
Okay. Coming back to this secondary hypertensive patients, as you said, the workup of a secondary hypertension is very costly and we should not do in all the patients. So what raises, if you see a patient with young hypertensive, what are the indicators which raise the suspicion? Because see, the most of the patients are coming to GPs. So what is their message for them? What should they look so that they can refer to you?
There was a whole slide on that. Like if age is less than 30 and there is no risk factor. Like risk factor in the sense of like the junk food, metabolic abnormalities like obesity or metabolic syndromes, features of metabolic syndrome, those things are not there. No drug abuse or something is there. Then if this person has very high blood pressure, like in the range of 200 to 120 or 200, 140. So very high blood pressure, usually these point towards a secondary hypertension or sudden jump in blood pressure. A patient was having a normal BP in the range of 120, maybe 120 by 90, 120 by 100, and suddenly he goes to 200 by 130 or something. There also we should suspect. Then, so there are certain clinical features like which I mentioned covered in detail, like radiofemoral delay is there. Some clinical features are the Cushing phases are there, or if there is palpitation and sweating, then we suspect for pheochrocytoma. And those are the features where we look for this basically.
So in the patients of secondary hypertension, which are the most prevalent you see? Which type? Pheochromocytoma or renal artery stenosis? What do you see most?
The study which I have shown is in that hypothyroidism was the commonest actually. Hypothyroidism, this was US study, hypothyroidism is the commonest. Otherwise, hyperaldosteronism is also should be suspected very often in these patients because that also has a large number of patients. But by study, if you go, it is hypothyroidism.
And seeing the young patients who are they have come with primary hypertension without any secondary causes. What is the causes mainly? Is it sympathetic overactivity? Is it caused in India?
Yeah, sympathetic overactive work stress, as Dr. Ashwini has also mentioned. Our work stress, our day-to-day life stresses, those lead to sympathetic overactivity, and these patients benefit with the beta blockers.
Okay. Thank you, Dr. Bharadwaj. So going to Dr. Mehta. So now going to the treatment aspect, Dr. Mehta, regarding beta blockers.
Yeah.
So in your patients with hypertensive with heart failure, which beta blockers do you present? Because you mentioned about 3, but in your practice, which you prefer? And how is metoprolol fit? Metoprolol, succinate fit in all this scenario?
In fact, to tell you very frankly, patients who are already on beta blockers and then like if they are on metoprolol or bisoprolol or carvedilol and they come with heart failure, so I typically continue with the same because these patients are comfortable with that and I don't see switching over from among all these 3 has any great role. So I continue with those beta blockers, but if I have to start a new beta blockers, my preference has been primarily between metoprolol and bisoprolol and not so much with carvedilol because most of these patients we want to put them on other drugs also like ACE inhibitors or ARNI, MRAs and other drugs. So with carvedilol you do see a much significant drop in blood pressure along with other drugs and you do not reach the adequate dosages faster. With metoprolol and bisoprolol, both of them have an advantage. And in most of my patients to begin with, I would start with either of these 2, either metoprolol and or the bisoprolol in a very low dose, and then would like to up titrate them. In fact, the lowest dose of metoprolol succinate, I prefer to start in the first part as the first line therapy in many patients, along with ACE, along with MRA, and along with diuretics. So that gives me an advantage of starting all the drugs early, faster. And I do have a preference of metoprolol and bisoprolol both in my practice.
Okay. Do you also monitor the heart rate in these patients?
Yeah, I in fact very very regularly, and aim to have their heart rates low and preferably less than about 65, preferably around 60. And over the years, I am been part of many international trials with which we have used guideline directed medical therapies, and I am absolutely certain about that controlling blood pressure, controlling heart rate, especially in heart failure, is a very important thing, and it does improve the outcomes in many patients. And there have been previous studies which show that if you take care of the chronotropy, it does improve the remodeling of heart and the outcomes.
Okay. And in spite of optimal beta blocker therapy, what do you do if the heart rate doesn't drop below, say, 80, 75, it is not dropping? Beta blocker, you don't want to raise it further. So what do you do in these patients?
I typically would add ivabradine to such patients, and I'm quite liberal in my use of ivabradine on top of beta blockers. And sometimes, like you said very rightly, that majority of our patients on heart failure, we can't reach the target dosages of beta blocker. But still, if we can't reach the target dosages in whatever dose of beta blocker they are on, to reduce the heart rate, we add ivabradine to them, and it's very common practice among all the cardiologists. So.
Okay. We saw in your presentation you have classified heart failure into 3 parts, and you have said that in preserved ejection fraction the role of beta blockers is limited. So can you just shed more light on that matter?
The problem with HFpEF has been that none of the trials have been very, very categorical in saying that this drug is superior. With HFrEF, we have had very good results with trials with beta blockers, one after the another, which have proven that in HFrEF, if you give beta blockers, outcomes improve. Whereas in HFpEF, there is no trial which is very clearly shown that any particular therapy improves the outcome, other than the TopCat study. And in TopCat study also there has been some controversy with MRAs that when the data from Eastern Europe and Russia was removed, all that part, so then it did show that most of the patients, they improved with MRA. With beta blockers in HFpEF, patients who have atrial fibrillation, who have fast heart rates, they are the ones who benefit a lot with beta blockers in this particular subgroup, HFpEF. But other than this subgroup, and another group which can benefit is who have ejection fraction later on the lower side. But otherwise, it has not been proven in trials to improve the outcome significantly.
Yeah, that's very important, Dr. Ashwini, which you have said, that actually diastolic heart failure or preserved ejection fraction heart failure, that's a sort of syndrome. There's multiple etiologies like atrial fibrillation, and then there's hypertensive patients who go into that. So with multiple etiologies, one cannot have a single drug. That's the basic thing. So with atrial fibrillation, it's acting. But then the other categories there are 6, 7 categories they have devised where you can have heart failure with preserved ejection fraction. So you really cannot have a single. People are trying to have a single drug for that, which is not possible because etiologies are different, the mechanism will be different, and hence you will need different drugs. So for subcategories, you will have certain drugs, but you cannot have a single drug for all. That is my take on it.
Absolutely, that's what I mean to say.
Okay, Dr. Bhardwaj, so coming back to you. So now we have a young hypertensive patient, maybe 25, 30, and has many more years in front of him or her, and you are diagnosed him or her with primary hypertension and you want to put on treatment. Now there are few things which comes into the mind, say from a GP's mind or CP's mind. You are a cardiologist, you are a specialist, but from their mind they have to keep few things in mind. Say beta blockers, the worry is that the patient may develop impotence in the early reproductive life. Then there is another worry is that some of the drugs they cause increase the insulin the resistance, so might become diabetic in the future. So metabolically they are not friendly, some of the antihypertensives. So what do you choose? You see, as you said, most of the patients are high sympathetic overtones. So how do you treat these patients?
The first and foremost in my practice is lifestyle modification.
Okay.
So stress on their food, stress on their salt intake, stress on the less fat, then good physical exercise, lots of fruits. All those things are very important, and studies and all the societies, whether it is American society, the European and NICE, all of them say that lifestyle should be given good time for the patient to recover. In case they don't respond to that and still they are having high blood pressure, then I'll think of. Now beta blockers definitely if patient has high sympathetic tone and because of that his BPs are high, then beta blockers, we do give beta blockers. If you give them in a very high dose, those side effects come into picture. If you give them in normal dose like 25 milligram metoprolol, I have not seen that it really causes impotence. Once in a while it can be there, but it's not a very big sort of percentage of patients. And in those cases, sometimes I've used bisoprolol because this side effect is less. So that is one of the way out. But usually beta blockers they tolerate well. And as far as same is for insulin, this thing is whether these patients tend to be diabetic. The same has been shown and has been seen that it's with the doses which we commonly use, these side effects are not that prominent. So we are quite happy with that. But I'm not using beta blockers in all my young patients. I do put them on ACE inhibitors, angiotensin II blockers, and if required, if their heart rate is higher side and if I feel that the sympathetic tone is on the higher side, then I put them on beta blockers.
Okay.
Yeah, I'd like to add on another point that most of the side effects which have been attributed are attributed to non-selective beta blockers and high dose, both. And in fact, there is a study with bisoprolol, and which did show that it is absolutely safe as far as impotence is concerned. And number one. Number two, there are studies which have been done in patients of COPD with bisoprolol and also of metoprolol in the lower dosages, not in very high dosages. There are studies in diabetics which have all shown improvement, which have all shown reduction in mortality. So there is no need to be worried about it unnecessarily regarding beta blocker use as far as these things are concerned. The traditional beta blockers and the new beta blockers are different, like I showed in my talk also. And so many studies have proven that beyond doubt that if you do not use metoprolol in a very high dose or with bisoprolol even in a little bit higher dose, there is none of these things which we usually see. And as far as impotence is concerned, it is mainly the stress which is playing a big role in younger people, as Dr. Bhardwaj has rightly said, leading to impotence and also hypertension. So if your lifestyle can help in both.
Okay. Dr. Bhardwaj, now coming to the selection and of antihypertensives. So do you tend to start with monotherapy, then keep on adding, or you add with the combination? You can start with the combination.
In young people, monotherapy. In older people, now my dictum is combination, mostly combination, but the young, usually we are able to manage with monotherapy. That is my way out. I don't know whether any guidelines are there on the direction, but my way is easily we can manage with one drug and if required, second drug. And this is for primary hypertension. Secondary hypertension, you may need to add 2 drugs at a time, but the primary hypertension, good lifestyle, and then one of these drugs I commonly do add is ACE inhibitors or angiotensin blockers, these patients, and if we are suspecting that there is lots of stress and sympathetic overactivity, then I give them beta blockers.
Okay.
Single monotherapy, monotherapy.
Okay. So ACVD risk score, basing so some of the guidelines, they also base their treatment on ACVD risk score. So young patient, do you do ACVD risk scoring or do you wait till 40? Because the score says that the patients So that's a tricky thing. So what do you do?
I've covered this point also. Scoring it should be used more in older people because their 10-year risk is very, very clear. You can make out the risk. Whereas our younger people, their 10-year risk is not much, despite all the risk factors. They will die, they can be anything, but their risk factor is not that high. But their lifetime risk will be high. So scoring is not that good, except that there was a Q risk score 2 was there. Now they have Q risk score 3. Where they have included lifetime risk that they have included in that. That sort of score you can use. I haven't used that score, but it's there in the books. And otherwise, score calculation of 10-year risk is not sort of advocated for younger people.
Okay. So the next question we have for both of you. We'll start with Dr. Mehta, and then we'll take points from Dr. Bhardwaj, you as well. So both of you, this is a common topic of discussion. The role of SGLT2 inhibitors in hypertensive with heart failure with or without diabetes. So Dr. Mehta, what is your take on that topic? Are you pro or against it?
Well, as far as hypertension is concerned, I am not bothered whether the patient has diabetes or not. My role of beta blocker is same, whether the patient has diabetes or not. And I would like to definitely give the RAS system blockers to these patients. And if indicated, if it's complicated, then would like to add a beta blocker also. And it is not related to diabetes at all. With diabetes, I do not see any limitation of using beta blockers.
It was SGLT, I think. He said SGLT.
SGLT2. Okay. Yes. The SGLT2 inhibitors definitely have a role as far as hypertension and heart failure is concerned, but no role whatsoever in hypertension. And we know that they do reduce blood pressure a little bit, but they have not been good antihypertensive drugs per se. But definitely patients who are diabetic, and if we want to reduce the risk of heart failure, then SGLT inhibitors do have a role, specifically in certain phenotypes who are at a higher risk of developing heart failure. For example, those who are diabetic, hypertensive, and those patients along with diabetes who are obese, or who have atrial fibrillation, elderly, in all these, or coronary artery disease, I would prefer to use SGLT2 inhibitors along to reduce the risk of heart failure. But hypertension or no hypertension, SGLT has no role.
Okay, and what about hypertension with heart failure?
Heart condition with heart failure, now the US FDA has mandated the dapagliflozin to be used in all patients, whether they have diabetes or not. And I am a part of one very large trial, which is the Emperor heart failure studies, both reduced and preserved. I am the principal investigator for that. I was also a part of DAPA-HF, the result which came out positive. And although we don't know the results, but definitely I think SGLT2 inhibitors were discovered as diabetic drugs, but then they are the drugs which are modifying diseases in the sense that they are disease modifying drugs. And on one hand, they reduce the glycosuria, they do cause glycosuria, reduce the HbA1c, but then they are primarily having a lot of effect in reduction of heart failure, improving renal outcomes, and probably would also have an effect on NASH, the non-alcoholic steatohepatitis. So the fourfold effect you do see, and these are terrible and they're quite promising and a wonderful disease modifying agents.
Dr. Bhardwaj, over to you. What is your take?
I totally agree. I totally echo with Dr. Mehta. He said very rightly covered it that with diabetes definitely, now without diabetes also, heart failure, we are open to it now. I think will be used in times to come to much larger extent.
Okay. So we have a question from the audience, one question. So how do you manage diuretic resistance in a patient of heart failure?
मीटिंग में हूँ अभी तेरे को भेजा नहीं मैं भूल गया हूँ शायद भेजना अभी व्हाट्सएप करता हूँ
Dr. Mehta.
Yes, can you repeat your question?
Yeah. So how do you manage diuretic resistance in a patient with heart failure?
Yeah, in fact, there are various ways to manage diuretic resistance, and one of the predominant we see that many patients are not on MRAs. So if you give MRAs in a proper dose, if you add on MRAs who are not, they do improve. And then another very important thing is that many patients who have diuretic resistance, you can try and give them metolazone. Metolazone is effective even at the GFR rates of less than 25 when a lot of other diuretics might not be so effective. And the another way is to increase the dose of diuretics. This is the simple way of overcoming the diuretic resistance in heart failure patients.
Okay. So Dr. Bhardwaj, if you talk about the diuretics, I mean, thiazide-like and thiazide-type diuretics in the treatment in hypertension. So what do you prefer? Is it CTD is there, indapamide is there, hydrochlorothiazide is there. So out of the three, what do you prefer, even alone or with combination?
Long acting are preferred. Like there was this study which definitely said that chlorpropamide, because it's longer acting and it has a longer effect all over 24
Yes.
hours, effect is there. So it's I prefer that definitely. Then there was a study after that which said thiazide is also equivalent, but I still prefer CTD because this is long acting. Indapamide, it is metabolically more safe. That is one of the points in favor of that. I've been using chlorpropamide and this thing, indapamide, both of them, less of thiazides.
Yes, in allied study it is found to reduce heart failure compared to even the ACE inhibitors, it is found to be beneficial.
Yeah.
So there's a question, Dr. Bhardwaj, for you from the audience. How does low birth weight is associated with hypertension?
Low, I've mentioned that also. Low birth weight, basically they said that this nephron mass is less. Nephron mass is less, which ultimately in some way leads to decreased renal function, a sort of latent, sublatent decreased renal function and hypertension. That is the basic theory is that the nephron mass is less at birth in low birth weight kids. That's the basic theory.
Okay. So thank you both of you, for your wonderful presentations, and definitely you answered a lot of questions from our end. So we are almost 1 hour 20 minutes into the program, so it's time we come to an end. But before the program ends, we'll take key messages to the audience from both of you. So we'll start with Dr. Mehta. What is your key message to the audience with regard to today's presentation?
Well, I would like to tell very clearly, as far as my talk was concerned, it was focusing on beta blockers. And I would like to say that beta blockers is a very important therapeutic area, which has been much maligned of late, but then it has its own role and you can judiciously use it, specifically beta blockers. You cannot just treat patients with heart failures, arrhythmias, coronary artery disease without beta blockers, and specifically certain group of young people who have raised sympathetic tone. And also consider beta blockers along with other antihypertensive drugs whenever you're treating hypertension, which is not getting controlled. So this is a simple and a straightforward message as far as beta blockers is concerned in hypertension. And as far as heart failure is concerned, today we have option to treat HFrEF very effectively. We have the armamentarium of using ACE inhibitors, MRAs, diuretics, beta blockers, and ARNI drugs, and also now SGLT2 inhibitors. Huge number of drugs. But as far as HFpEF is concerned, we have limited amount of choices. But remember, with heart failure, beta blocker are the pivotal drugs. You can't do without beta blockers. Do consider using them adequately.
Thank you very much, Dr. Mehta. Dr. Bhardwaj, your key message to the audience.
My key message is that in young people, hypertension is not that uncommon as we generally think. It's really coming in epidemic proportions, and it's really going to lead lots of these complications in the form of cardiovascular, kidney disease, or cerebrovascular. So we should suspect them and do, wherever possible, do screening to diagnose them. That's a very important message, because if we miss them at this juncture, it will really lead to complication. Then they will end up with complications. So very important preventive measure that we should check and do screening wherever possible and detect it. Second is that as commonly thought that young hypertensive or secondary hypertensive, no, 90% of them are primary hypertension, where it is associated with some lifestyle diets or salt or stresses and those things. So we should treat those, and in every case you need not go for costly tests like secondary hypertension. There you have to very specifically target where you have to do those costly tests, renin and those tests. Most of the other cases, routine tests, you can manage these patients. And last but not the least, lifestyle modification is the key. You have to stress very hard into their brains that you have to have a very good regular diet, low-fat diet, not unsaturated fat. Saturated fat should be very less, low-salt diet. Put 40-45 minutes of regular exercise and do relax in between. And don't stress too much for work and all those things, I think. So that is the key message.
Thank you very much. Thank you, Dr. Mehta. Thank you, Dr. Bharadwaj, for your excellent oration and the discussion. Discussion was very good, interactive. And I'll also like to thank the technical support team for the continuous support during the program, and the Ipca team for managing the program, for organizing the whole program. So hopefully we'll come back in the future with some more different topics. Till then, I would like to say goodbye to both of you, goodbye to the audience. And in this corona time, definitely first priority is that stay safe, stay in a good health. And so thank you very much and see you soon. Namaskar.
Thank you so much, Dr. Bharadwaj and the Ipca and to Dr. and all the audience who have joined in.
Thank you.
Thank you.
Thanks.
Recording has stopped.